Hello, this is Anna Miller. I had case A. So this is Will, a 28-year-old man, new to my care, has a history of asthma, comes to the clinic today complaining of wheezing, shortness of breath, and cough. He's only using his inhaler, but it's not working. His inhaler is salmeterol. So based on that information, I kind of put together my thoughts, and here's what I have. So it's helpful for me to go through the pathophysiology of asthma to be able to generate a treatment plan, rationale, and to be able to determine Will's severity. So asthma is a reversible chronic inflammation of the airways, which makes them narrow and difficult to breathe. It's typically triggered by substances in the environment, such as allergens, through the route of inhalation. Medications and pollutants can also cause airway irritation, so that was significant for me to note. Foreign substances generate an immune response reaction, which causes the inflammation in the lungs. This can sometimes narrow airways to the point of severe airway obstruction and can be life-threatening. Asthma can be classified according to the frequency of symptoms, in particular nighttime or early morning symptoms, symptom severity, and degree of impairment of pulmonary function. So pulmonary function tests include FEV1, or forced expiratory volume in 1 second, the peak expiratory flow rate, or the FEV1 over FVC ratio, which can measure the level of obstruction of the airway. Asthma can also be classified by frequency of medication use. From least to most severe are intermittent asthma, mild persistent asthma, moderate persistent asthma, severe persistent asthma. So intermittent asthma is defined by symptom frequency less than or equal to 2 times per week with no interference with daily activity. Waking up with symptoms less than 2 times per month, and the use of short-acting beta agonists less than or equal to 2 days per week. The FEV1 is usually greater than 80% and has a normal FEV1 over FVC ratio. Moderate persistent asthma is defined as symptom frequency greater than or equal to 2 times per week, waking up because of the symptoms 3 to 4 times per month, using short-acting beta agonists greater than 2 days per week, and there's minor limitation of daily activities. With this one, there's normal pulmonary function tests. Moderate persistent asthma is defined as the daily symptom frequency and waking up because of symptoms greater than once per week, some limitation in daily activities, daily use of short-acting beta agonists, and FEV1 ranges between 60 to 80%. And then the FEV1 to FVC ratio is decreased by 5%. Severe persistent asthma is defined as daily symptoms throughout the day, waking up because of symptoms every night, extreme limitation on daily activities, and using short-acting beta agonists several times a day. The FEV1 is less than 60%, and the FEV1 over FVC ratio is decreased by greater than or equal to 5%. This information was from Colace, 2004. So the treatment typically includes avoiding your triggering substance. Medications include bronchodilators, which can be short-acting or long-acting beta agonists, and anticholinergics to help relieve or relax smooth muscle contraction in the lungs and help dilate the airways to increase airflow. Individuals with severe forms of asthma require daily corticosteroids, long-acting beta agonists, or local treatment of antagonists. Very severe cases require intravenous corticosteroids, magnesium sulfate, and oxygen therapy. In general, intermittent asthma is treated with short-term beta agonists as needed. Persistent asthma requires daily medications. Mild persistent asthma is typically treated with a low dose of inhaled corticosteroids. Moderate persistent asthma was typically treated with a low dose of inhaled corticosteroids plus long-acting beta agonists, or a medium dose of inhaled corticosteroids. Severe persistent asthma is treated with a medium dose of inhaled corticosteroids plus your long-acting beta agonist, or a high dose inhaled corticosteroids. If symptoms are not relieved, you can consider adding biological agents such as oral corticosteroids, or it's called Amazolab. And this information was taken from Chips et al. 2022. So based on my patient presentation, they came in with wheezing, shortness of breath, and cough. He can be having an exacerbation right now. He reported that he's currently only taking a long-acting beta agonist, which has not been working. It's unclear whether he's had his symptoms daily or sporadically, and I don't have his pulmonary function tests at this time. I also don't know the frequency of his inhaler use. The most important thing in this patient to know is if he's having an asthma exacerbation currently, or if this is concern for impeding respiratory failure. I would start first in my evaluation of checking his ABCs, so airway, breathing, circulation. I would want to know this just based on his clinical picture. I would classify his degree of asthma exacerbation based on his clinical picture. His clinical presentation and physical exams include findings of respiratory distress. But I want to know, does he use his accessory muscles to breathe? This would also help me know if he needs to be admitted for an acute asthma exacerbation, if there's a need for possible intubation, and if I should use short-acting beta agonists versus short-acting muscarinic antagonists, and then if there's a need for IV corticosteroids. If there are no signs of asthma exacerbation, I would want to know more of a history, as well as get a set of pulmonary function tests. This would help me determine the severity of his asthma. Long-term treatment could then be modified for his severity degree. So what I know about him so far is he's on a long-acting beta agonist, so I would suspect that he's either at moderate persistent or severe persistent asthma severity. At this point, due to my lack of information, I would think about adding a low dose inhaled corticosteroid to his regimen, as well as using the long-acting beta agonists. If improvement is in his symptoms are noted, I would continue the combination of the low dose inhaled corticosteroid and long-acting beta agonist to treat the suspected moderate persistent asthma. I would schedule a close follow-up appointment to monitor for symptoms of improvement or stability. However, if his symptoms do not improve with this regimen, I would titrate up to a medium dose inhaled corticosteroid plus the long-acting beta agonist to treat for severe persistent asthma. My rationale behind this is you want to treat, it's kind of that fine line of finding the lowest dose and potent agents that can treat his symptoms and control his symptoms. And at the follow-up, I'd want to have him bring a log of his symptoms, frequency, exacerbations, which would give me more information to better manage his treatment regimen. Along with this, I would want to add asthma education, such as the importance of the short-acting beta agonists in those acute situations and severity of symptoms, as well as avoiding his triggers and what we can do to prevent his future asthma exacerbations. Information from that rationale was taken from Hagasawa 2021. So that is my rationale on the case study. Thank you for listening to my thoughts.